That is correct. Well, we're in a new place now, you know? I think we're talking about this. The way we think about this is taking new dimensions. If we avail ourselves of this opportunity to fill them up, we're going to have new interventions. We're going to be able to identify people at risk who otherwise would be. I'm a pilot now. I fly at the sheriff's station. San Francisco. Sheriff's next day for law enforcement. But if you behave yourself, I won't arrest you. Are you a flyer, or what do you do? You're a doctor? Well, some doctors are flyers.
Hi everyone. We're going to get started. I apologize, I was late. I've had a busy clinic today, but really fascinating patients and thinking more and more about personalized medicine, advancing care, and using molecular diagnostics and strategies to think about patients and applying them to them. And luckily, that's the focus of our talk today with our phenomenal speakers. My co-chair, Dr. Stock, who is the Cardiology / Endocrinologist extraordinaire, and actually her mentor.
You ought to
Dr.
hear her sing.
I know, we'll save that, and Dr. Kane. So I'm looking, Dr. Stock will introduce him, but I just wanted to welcome all of you back to the RightCare initiative. We have had some great talks over the year, actually almost been a year, a couple more months and we'll hit our year mark. And I really enjoyed meeting each of you. I think because I'm a little bit late and for the sake of time, we won't do the full introductions today. But please, if you do make a comment, just introduce who you are so we kind of get some context. But I think we'll just welcome you all and get started. Hattie, did you have anything else you want to add?
I think at the end I can talk about our CDC meeting, but I don't want to cut the molecular discussion short. So. Thank you, Dr. Kane, for being with us, and Eveline is going to do the formal introduction.
Okay, so we are lucky today to have Professor Dr. Kane, John Kane, who is currently the director of our Lipid clinic and an associate director of the Cardiovascular Research Institutes at UCSF. He has a very long track record of research in lipoprotein metabolism, management of lipoprotein disorders, genetics of cardiovascular disease and stroke, and he's known worldwide. He obtained his medical degree at the University of Oregon School of Medicine, completed his residency in internal medicine here at Stanford. But then we stole them at UCSF, and we managed to keep him there for his whole career. So he has received an Outstanding Achievement Award from the International Atherosclerosis Society for his work in genetics of lipoprotein metabolism and atherosclerosis. And Dr. Kane, if I went on with all the contributions you have made to the field, we wouldn't have time to hear you speak, so I'll stop right here. So.
Thank you for being here.
Well, I'm particularly pleased to be here because I am very impressed with the potential for combining the rapidly developing new insights at the molecular level with clinical medicine. And I'll just start out by telling you a couple of stories to know where we're going. One, I started by telling your assistant out here about the fact that about 100 years ago, there was a doctor in Germany by the name of Wohlmann who described a disease in young infants. They would be born normally, and then the liver would start enlarging, and the liver would go into failure, and the child would die in the first 18 months of life. And he thought it was hereditary. Mindfully, didn't know what a gene was in 1919. But because there was more than one in a family. And so he said there's something about this, that they inherit this. It took another, till 1985 or so for a colleague of mine at the University of Oregon to find that what was happening, the liver was filling with cholesterol esters. They thought it was fat at first because it was translucent to light. But they found that quickly. Another colleague of mine at another university found an illustration of how we ought to collaborate. Found the enzyme that does this from cholesterol esterase. Another one quickly found the gene for this. And then colleagues of ours in Boston put the gene into vertebrate cells and produced a recombinant protein, recombinant lysosomal acid lipase. We've just finished a 2-year clinical study with this, Dr. Mary Malloy and I, with colleagues in Prague and Kyoto and Berlin and many other places. And the paper has just been sent off for publication. I'll share the results with you. Complete reversal of this disease. 4 years ago, we would have to tell the parents, your little Letitia probably will not be with you by Christmas. Now, Letitia's going to grow up, go to high school, probably dance in the prom, and go to college somewhere, and Lord knows what she's going to do. But these children are restored to a full lifespan. It requires 2 injections a month. I mean, we have diabetics who get 4 a day, so you know. So I think this is an example of where we can go at the molecular level if we concertedly see where these targets are. So today I'm going to share some of these things with you. I'll share another couple of quick observations. In the last few months, I've been seeing a woman at UCSF who has an LDL cholesterol of 950 and sometimes 1,000. She has huge xanthelasmas around her eyes, and the interesting thing is that she's only recently had any touch of coronary disease. She just turned 81. Now, what is it about this woman? The first 2 children that I encountered with homozygous familial hypercholesterolemia, which is what she has, each died at the age of 11 of an MI. So there's something very particular about this woman, and I believe it's genetic. Last week, I saw a young lady, 31 years of age, with heterozygous familial hypercholesterolemia. She's already had her first heart attack. So I think genomics is going to tell us a great deal about not only who's at risk, but what mechanism may be involved. And because people with that disorder I first described in the children, if they're heterozygous or combined heterozygosity without full activity, they can live into middle age and so on. And they'll look like familial hypercholesterolemia. It's a totally different mechanism. We're seeing people who look as though they have FH, who don't have cholesterol at all. They have plant sterols, a condition called phytosterolemia. So, you know, I think we need to sharpen our diagnostic approach, because those people can be cured with ezetimibe, ZD, 10 milligrams, that's it. So, I think developing this molecular view, mechanistic view of disease is where we need to go. And this is already to translate into the kinds of things you're thinking of. Actual practical application in epidemiology, systemic clinical medicine, where we are really watching for risk in the first place and then effective interventions. So I'm going to take you on a molecular tour now and share with you, I think, some of the exciting things that are developing and how so many of these right now are translatable into the kinds of things we're thinking about. So where do I do? Oh, okay. This is advanced.
Yes.
Okay. Okay. And this one corrects me if I'm wrong. I have to warn you, I used to have a radio talk show, so you only take 80% of what I say seriously. Okay, so we're going to go through these emerging themes. So what are the statistics here? Well, I probably don't have to tell you this, but cardiovascular disease affects 121 million Americans, and it's the leading cause of death. The leading cause of disability is cerebrovascular disease. They're all in the same mechanistic group here. And over 95 million Americans have dyslipidemia, and that depends on how you define it, because we're finding new kinds of disorders that the conventional testing doesn't tell you about. And so, for instance, we'll get to it later, but we discovered a few years ago an HDL particle that nobody had seen before. We called it pre-beta 1 HDL and started looking at it, and it turns out that this is the particle that accepts cholesterol from when it's effluxed from tissues. Efflux of cholesterol is just as important on the positive side as accumulation of cholesterol is on the negative side. If you can get rid of cholesterol better, you're better off. And what we found is, by measuring this particle, that we can classify people for their ability to efflux cholesterol. I feel like that's something we never could get at before. So this is one of the new dimensions that we'll be bringing in. Healthcare costs, of course. Why isn't this? Get some ideas here. Do I hang it on the floor? Stamp my foot. I can just wing this, of course.
There we go.
Okay, so, well, let's see what's happening, how this gets mixed up with other disorders. We know that heart disease by itself is deadly, but when you combine it with diabetes, which runs fairly commonly in our population, look at this. You can read this probably, but look at the combination of diabetes and coronary disease when you put them together. And we understand a lot of pathways now that are developing that explain why people with diabetes have abnormal lipoproteins and why they have many other defects, particularly involving inflammation and coagulation and so on, that add up to a serious combination. So I'm going to try to develop 3 spaces here for coronary disease and cerebrovascular disease. The first of these we've had for probably 75 years. The recognition that certain lipoproteins in plasma wind up in the artery wall. And LDL was the first one identified, and they made a lot of that in the Framingham study and so on. And that's about the time I started doing lab work. And I was finding triglyceride-rich lipoproteins were involved. Oh, this was a new idea. Nobody was measuring that at the time. So we know now there are a number of different classes, and one of them that's really coming on center stage now is LPA. LPA is an LDL-like molecule that's attached by a disulfide bridge to another molecule that came from a repleted gene for plasminogen. So it has the Kringle structure of a clotting protein, but it isn't directly involved in dissolving clots anymore, or providing clots for thrombogenesis, but it messes up the process of dissolving clots. So this is how it's caused a lot of pain. It's involved in coronary disease, it's involved in carotid disease, and now it's very well established that it's involved in aortic stenosis. And LPA protein has actually been isolated from the aortic valve now, very recent publication. No question, we have these, and who knows what else it may turn up doing. We have to keep an open mind. But we're very interested to find out why we have this. Why did our ancestors acquire this thing? The plasminogen gene got repleted, and then we underwent mutations, and now higher primates, that is gorillas and stuff, and us, have this, and nobody else does. And so we're actually preparing it to send around to virologists and so on around the world to find out if we get some idea of why we have this thing. What is it? Is it killing an organism or what? We have a little precedent for that because we found a new protein in HDL a very few years ago. I called it ApoL because the apolipoproteins come all the way down from A, B, and C, and now they're on to M and N. So that's how complex this whole thing is. And we isolated this thing called the ApoL1, found that there are 6 of these genes actually. And collaborating with some people in Belgium, we were able to determine that that protein kills the trypanosomes of African sleeping sickness. Okay, this is not something we anticipated, but it shows how integrated biology is. There are 5 more of these genes. I was at a meeting recently where somebody told me that one of the other ones has now been found to kill poliomyelitis virus. So, you know, wow, let's look for the other 4 now. So, the lipoproteins are very important because they wind up in artery walls, but also because they're involved in thrombogenesis, they're involved in inflammation, they're involved in a lot of other roles. So we have a lot more to learn, even though we've been working on it for a long time. The second space I want you to think about mechanistically involves inflammation. We've known for a long time that inflammatory diseases like, oh, what did I do? Did I do that?
No.
Or did I time out? I'm supposed to stop talking?
No, I'll let you know when that is.
Okay, come on, tap me on the shoulder. So, but we've known that psoriasis is associated with more coronary disease and lupus, and so we had the idea, besides which, people looking at plaques, arteriosclerosis, they found interleukins, they found a lot of inflammatory molecules. So they were telling us that inflammation was important, but then the CANTOS trial came along. Maybe you're all aware of this, but using a monoclonal antibody against interleukin-1 beta, they were able to reduce new coronary events in post-MI people by 31%. We'll look at those data later. So now we know that inflammation is the second space. Okay. Am I asking what I do? Oh, no, you're fine. Okay. So anyway, so what's the third space? The opportunity to understand how the artery gets rid of cholesterol. This is something we knew about for a few years, but we couldn't measure it because it's very complex. You culture cells and you watch the cholesterol move and so on. It's not something you can do handily. Until we found and began to measure this molecule, pre-beta-1 HDL. When we did that, suddenly we found a very strong correlation between the level of that lipoprotein and the ability to efflux cholesterol. So we're able to get in the third space now and measure that, and the risk attendant to that is so huge. The risk calculation, a ratio of 2.0 C-reactive protein is 1.24. So we're into a new place where we can find people who maybe look good from their LDL standpoint and look good from other measurements and can't get the cholesterol out of the cell. Something entirely different. A few years ago, a doctor would have patted that patient on the back and said, "Oh, your LDL's fine, don't worry about it." And this is another cause of coronary disease, the third space. So this is the way I want to think about these things with you. Cardiovascular risk, they started out thinking that LDL was important. And I said, well, maybe you should measure triglyceride. When I went to public health service for a couple of years, here's what was found. So other lipoproteins are a risk. LDL, yes, triglyceride-rich lipoproteins, now LPA, who knows what else? There are some minor species. So we're expanding that field. A little bit of the background. Where do the lipoproteins come from? When you eat breakfast with some fat in it, you form large lipoproteins that are not shown here, called chylomicrons. They have their own B protein on them, B48. And they go into plasma where enzymes like lipoprotein lipase remove the triglyceride, the fatty acids go into tissues so you can take your morning run, that sort of thing. And they form a remnant particle which goes to liver. They never go beyond. The liver makes a triglyceride-rich lipoprotein when it has too much fat, if it's able to do that. And I'd like to say at this point that a big this problem that we have is what's called fatty liver, hepatic steatosis, and it's really combined with these other disorders mechanistically. So we can think about that when we're thinking about coronary heart disease. But the liver makes this triglyceride-rich protein, lipoprotein, and the protein on it is B100. I have to tell you how that came about because I named those. I started to give them other names. I sent the article in to the journal, and they wouldn't accept that. They didn't like my names. So I said, okay, this is because this is made from the same gene as this one, and it's 48/100ths of the length of the big one, then that's B48, okay? Made some, and they accepted it. So that's where that nomenclature came from. It took me 3 reiterations to get the thing published. Okay, so, but this differs in that VLDL becomes a remnant, losing triglycerides like chylomicrons, comes back to the liver where the rest of the triglyceride is removed, and you make LDL, which has a longer half-life. This is where your LDL comes from, comes downstream. And so we begin to think now about, when you're thinking about this, you got to think starting up here. What's making too much of this and it comes around? There's a disorder known as familial combined hyperlipidemia, in which combined because you got high VLDL and high LDL. The problem here is overproduction of this. That's why you have it. This is the leading cause of dyslipidemia in the United States. So we really have to think about this. And it often comes along with diabetes and other disorders that compound to increase your risk. Tell me if I'm too slow. So when you see a patient today, a physician has to start thinking about mechanism. High LDL does not just mean automatically familial hypercholesterolemia. There are all of these conditions that can give you a high LDL level. And the doctor has to go through this differential diagnosis, and there are tests for each one of these. So this is what we do at UCSF. When we see that patient, we don't jump to the diagnosis. There even are secondary causes, patients who are very hypothyroid, early nephrosis, and cholestasis is very interesting. This is where bile can't come down the bile canaliculi normally. You make another lipoprotein completely. It's called LPX, the abnormal lipoprotein of cholestasis. It doesn't have any B100 on it. It's a leaf-like or coin-like structure. And we can actually find that by looking at the structure with electron microscopy. Same thing with hypertriglyceridemia. Look at all the things that are involved. Diabetes, alcohol, these medications. We were seeing profound hypertriglyceridemia with the anti-cancer medications in children with with leukemia and so on. Most of whom survive now, incidentally. I still have an acute memory of a 5-year-old child who died in my arms when I was a pediatric medical student on pediatrics. And he had an acute lymphocytic leukemia. About 4 months ago, I had a woman sitting in my office to have her cholesterol corrected. She had the identical leukemia, only she didn't die in my arms like he did. She was cured at George Washington Hospital with precision medicine. So we're in a different era, and I want to be in a different era of coronary disease as well as the Okay, so we have some therapy coming on because there are other complications. It turns out there's a protein called PCSK9 that sits on the liver cell, and it damps down the activity of the receptor. Don't work too hard. We don't want to get that LDL too low. We think maybe that's the case because it's been found that LDL competes with hepatitis C. And maybe that's why we evolved. We're the only mammals with high LDL. Rabbits have, 14 or something, and we have 120. And so maybe that's why. But anyway, so we've learned to knock this down with monoclonal humanized antibodies. There's also an RNAi coming on in the molecular development. And when you do this, we can achieve LDL levels that are very low. We've got people that are in their 20s in our clinic. We're beginning to be concerned about that because there's a recent publication from China, from large, 40,000 people or something like that, in which people with LDLs below 70 had an increased risk of cerebral hemorrhage. And there've been a couple publications like that before. And so we're trying to aim at, 60-ish for the level you get the benefit on the coronary disease, but you may not be increasing the risk of cerebral hemorrhage.
Can you just put a fine point on that, add a couple more sentences about what the proper LDL level should be?
Well, we don't know for sure yet, but what they found in the Chinese article, which was huge, now I have to say, I think Chinese have more cerebral hemorrhage than Caucasians have, so we've got to get this in the right setting. But there have been papers dealing with Caucasians as well. And so they set it at 70. It was very sharp. Below 70, you began to see it. Above that, you didn't. And so,
Why are we aiming for 60? I
Pardon me?
missed that.
well, I mean, it bounces around. I mean, somebody's 60 one day and 75 the next, but we don't want to go below 60 anyway. And it came on, and it was curved too, so there was very little at 60 and more at 50. So we think that we could, this is kind of a trade-off, because if you've got somebody with very aggressive coronary disease, you might get more advantage by moving down to 60 and accepting a very small risk, but you don't want to be at 25.
I haven't read that specific article, but this has come up, in the literature before, the issue of hemorrhage, and I guess we are always cautious about the comorbid risk factors that a patient might have, and in the Chinese population, there is a lot of hypertension, for example. I'm
Yeah.
not sure if they controlled for all of that or just for it.
Well,
That
I
was
think
an issue when it came
they
up.
did recently in this article. I'll give you the article.
That'd be great.
But there have been 4 or 5 publications in the past hinting at this in other populations. So, we have to be careful. And this is a process, it's ongoing. Okay, so we have some people, we do have some people who naturally have hypobeta-lipoproteinemia walking around with 25 milligrams. We were collecting people who were pilots in World War II up in Napa, and a gentleman there who had flown in Okinawa, and if anybody remembers where that was now, somebody reported last week that 42% of high school graduates in the United States who were polled did not know whom we fought in World War II.
Oh my God.
So, wait a minute, anyway, they're learning about vaping now, so, Anyway, we found this gentleman, we said, we found that your LDL is 25. He says, oh, you ought to see my dad. He's 103, his is 25, my uncle's 101, and so is his. So, there is familial hypobeta-lipoproteinemia that's not associated with cerebral hemorrhage. So there may be some combination of factors here, because, we see this, we have studied to some extent this disease, hypobeta-lipoproteinemia. And guy was still flying his airplane incidentally. So.
I just want to say that what you just said about LDL 70 is so important to our group and the practical work that we're trying to do here, because I have had multiple cardiologists say with a very high calcium score that the LDL should be less than 50. But there's dispute in this area, so it has such practical implications for how do you care for your patients. And what you just said is contrary to other speakers saying let's drive that even lower.
I'm quoting
So
the literature.
Really important.
But I think this is a huge study from China, and maybe Asians are different, I don't know, but there have been papers from Europe and so on. So I would be cautious. I think, 50, 60 is a good number, you don't want to go below that. We get patients referred in who've been put on these powerful agents who have, 14?
But they're not having hemorrhages in the literature,
Well, nobody's following that,
but in the study population. So I think
We've
it's
never seen
controversial.
one.
I think that
No.
that number is controversial. So I don't know if we.
I think we need to get an answer to this.
Yeah.
and-
So the European meetings a few weeks ago in Paris, European Society of Cardiology, they came out with their new guidelines on LDL. And they've lowered for polyvascular disease, so very high risk,
Yeah.
polyvascular, you can demonstrate vascular disease in more than one bed, carotid and coronary, for instance. LDL 55 or less, they've dropped their number. They've kept it less than 70 for high risk, not polyvascular. And there was a lot of debate about that in terms of that number. But it seems like, it seems like there's a move towards dropping that LDL number, certainly in Europe.
Well, I think